Hi, my name is Christina. I'm the unit leader on E3, B3, and the Express unit. I assist with patient flow, facilitate discharges, booking beds. I'm really kind of a go-to person on the ward. I help with the day-to-day running of the ward, staffing issues, patient issues, family issues. So I can be a resource person where to find forms that you need for discharge, whether it be to different clinics or home oxygen, the LIN program.
I'm Tanya. I'm one of the dietitians on E3, Satellite Express, and the ER.
And I'm Jill. I'm the part-time dietitian on F3.
So what does a dietitian do? We assess people for their nutrition assessments and what they need from day to day. Part of what we also do is we provide education to patients. We help facilitate discharge. Patients need something, Meals on Wheels or that kind of thing. We can help them with that information. And should you consult a dietitian, if someone has tube feeds or TPN, if they need a therapeutic diet, if they have malnutrition, we ask that you ask 2 questions when you see a patient in the ER. Have you unintentionally lost weight in the last 6 months? Have you not been eating for the last week? If they've answered yes to both those questions, then we would think maybe you should be consulting us. So again, if someone's malnourished, if they need nutritional supplements, if there's something like that, then that's when you would think about consulting a dietitian.
Hi, I'm Brittany. I'm one of the speech pathologists here.
And I'm Lauren Edwards. I'm another speech pathologist, and the 2 of us work on the entire CTU, so we'll see patients in Emerge, Express, E3, F3, B3, or off service. So in acute care, the role of the SLP is primarily to identify, assess, and treat swallowing-related disorders. We can provide some screening and referrals around communication impairments such as stroke or dysarthria if it's a new diagnosis. Some of the services we provide are bedside clinical swallowing assessments, which includes assessing oral motor function, respiratory status, cognitive status, ability to handle a bolus and swallow in a coordinated fashion. We'll look at oral hygiene status as well, and based on clinical assessments may refer for further imaging studies of swallowing, and we will participate in goals of care discussions with families if needed.
We require a written order in order to assess. A reason for consultation is usually because of the medical diagnosis. So anybody that's here for an aspiration pneumonia, a CVA, anybody that's been noted by staff for coughing, choking, difficulty chewing. We also help assessments with oral care, decreased oral intake. Those would be some reasons that you'd want to refer to us.
I'm Verna. I'm one of the occupational therapists. I cover E3.
And my name's Andrew. I'm an occupational therapist on F3. We assess people's functional abilities. That includes their self-care, productivity, and leisure. We look at people's abilities to toilet, continence.
We're concerned regarding any changes in cognition. If there's a change in baseline cognition, we don't necessarily need to be involved if someone has a known diagnosis of dementia or cognitive impairment, and it won't necessarily change their discharge destination. But if it's a change from their baseline and people are identifying concerns, we can become involved in terms of assessing cognition, their ability to return to their level of independence prior, or make suggestions around different alternatives to assist with discharge planning.
We also help with people's equipment in terms of mobility equipment, wheelchairs and walkers. We also help look at equipment needed for discharge, so we also talk with the LIN quite frequently.
We're also familiar with the different rehabilitation programs in our area and what people will qualify for. So we can make recommendations around rehab programs as well as referrals in terms of LIN program support regarding personal support. So a referral to us to help make those decisions is appropriate because it's based on a functional assessment. We can help determine what the level of care is that they require. We cannot assess for capacity. That's something that requires legal status to become a capacity assessor, and we don't do that in the hospital setting. We can give you advice regarding someone's cognition and their ability to understand the decisions they're making, but in terms of a formal capacity assessment, we do not do that. We also are not resourced to see people from long-term care. While they may have a change in their baseline function, unfortunately we don't have the resources to work with them in hospital. They'll have access to occupational therapy when they return to their long-term care facility.
Hi, my name's Carolyn. I'm a physiotherapist on E3.
And I'm Siobhan Davidson, physiotherapist on F3.
So we basically see patients who have come through the emergency who have a change in their mobility and their function. So we go by referral basis and we need an activity order as well. We get them up and moving, and along with occupational therapy work, we work as a team. At times we do refer to see if they're appropriate for rehab or if they can go home with the LIN service. We see chest physios as well, and these are your immobile patients patients with pneumonia. Best chest physio for other patients, we get a lot of referrals, is actually getting them up out of bed, getting them into a chair. If a nurse identifies that there's mobility issues, we will ask for referrals for those patients as well. Along with the long-term care patients, we just do not have the resources to be seeing all long-term care patients, and mobility is not a barrier for discharge.
One thing we'd like to encourage the residents to do is to try to mobilize your patient. So if you're auscultating your patient, rather than having them sit in long sitting in bed, which can be very awkward, assist them to the edge of the bed and auscultate. Believe it or not, just that little bit of mobility makes a big difference in decreasing their length of stay. If you can get them standing and into a chair, if you feel comfortable doing that, even better. So we try to promote mobility as a team issue between the staff and the hospital.
My name is Chris O'Brien. I'm the pharmacist on E3 and also part-time on F3. The majority of my time is spent processing prescriptions and dealing with any medication issues. We're also available for medication reconciliation, drug info questions, dosing recommendations, discharge issues, and patient medication counseling.
Hi, my name is Sue Swayze. I'm the nurse clinician for the geriatric team here at the Juravinski site. My role is twofold. I look at consults for geriatric rehab unit, which on CTU is generated by the OTs and PTs with a special order set. I also see patients for cognitive changes, delirium, depression, but we ask the teams to use our delirium order set to handle any acute issues with delirium before the geriatrician would be able to see them. The other, we do not assess for capacity, but we will certainly do a cognitive assessment to assist the team in determining what that patient's capacity is for whatever decisions you're requesting it for. We do not do psychiatric assessments if the patient is already seen by psychiatry. We request medical psychiatry see them in the hospital first. For discharge planning, we request that social work see the patient first, and if there are any issues with the discharge plan that social work has set up with the family and the team, then geriatrics would be more than happy to come in and assist with that process.